Hi, everyone. Good morning from Singapore. I'm happy to welcome all of you to today's webinar on the future of healthcare is at home, a dialogue with healthcare professionals. So we are glad today, and if we can go to the next slide, to welcome our speakers. We are very honored to have today with us Mary Kiang from Baxter, Mervyn Lin from ResMed, Marvin Adjon from Baxter, and Maureen Crocker from ResMed. The four of them are part of the APACMed Digital Health Committee. Thank you for being with us. And we are really glad to have with us our panelists and speakers for today's sessions. So Dr. Fu, she's director of Singapore General Hospital Peritoneal Dialysis Program. Dr. Kamongvan, she's associate professor at the Faculty of Medicine at the Thailand University. Dr. Chai is senior consultant at the Singapore General Hospital Sleep Center in Singapore. And Dr. Narisha, she's sleep medicine fellowship at the Memorial Hospital in Thailand. Welcome all, and thank you very much for your time today. Next. So this is a bit longer webinar that we usually do. Today we have a quite packed agenda, 1 hour and a half together we'll spend today. So we'll start with an introduction on remote care solutions by Mervyn Lim from ResMed and Mary Kiang from Baxter. They will provide you with examples and information on some remote care solutions they have in 2 different therapeutic areas. We will then start with the first session, remote patient management in renal care, moderated by Marvin Adjon from Baxter. And we will hear perspective, needs, and best practices sharing from the healthcare professionals who are using remote patient management solutions in renal care. Each session will be followed by a Q&A. So if you want also to interact with our speakers or ask any questions, please let us know in the chat. We will then follow with the second session. This time the focus will be sleep medicine. And this session will be moderated by Maureen Crocker from ResMed. We'll then end the webinar with a call to action at the end of this session today, and with some closing remarks. So if we can go to the next slide, before I start our speakers, before I let our speakers start, I will just tell you that this webinar is brought to you by the APACMed Digital Health Committee, which is a committee made of today more than 250 individual members from 75 companies across the Asia Pacific. Our objective when we were created a couple of years ago was to, number 1, share and create knowledge around digital health, and number 2, advocate for regional policies that can enable digital health in our region. So you see here our areas of work, from cybersecurity to interoperability to reimbursement and regulatory affairs. And if we go to the next slide, I will just like to tell you that this year has been the year of the remote care initiatives for APACMed. So we started with a symposium on remote care management in May, where we focused on the industry. We then continued with a series of dialogues with policymakers in July and August. The result of these 2 dialogues between public and private industry and sector is a paper that has been released a few weeks ago and is today available on our website. And you see the cover here, Advancing Remote Healthcare During and Post-COVID-19. So if we go to the next slide, I am very happy to end this series of initiatives this year with a dialogue with healthcare professionals. So I'm sure this will be only the first of a number of dialogues where we would like to hear more from the healthcare professionals moving forward. I will now like to introduce our first speakers for the session, Mervyn and Mary, from respectively ResMed and Baxter. So next, over to you, Mervyn. and welcome again. Thanks for the support and for being with us. Thanks.
Thank you, Roberta, and good morning to all our panelists and colleagues, and also to the audience. So what we want to do is just to give you an introduction, starting with me first, on the respective remote monitoring solutions that ResMed and also our Baxter colleagues have on the market. And specifically for ResMed, this would be in the field of sleep care, basically for patients with sleep apneas and other sleeping disorders. Could I have the next slide, please? Yeah. So it's been a couple of years since ResMed started deploying remote monitoring solutions into our CPAP machines. First starting with markets in North America, Europe, and then finally in the last 2 years gaining traction in Asia. So essentially the technology is simple, right? We use an SD card in our machine that monitors sleep, and then the attending healthcare professionals or home care providers will then provide advice and also analysis. What we have done is to allow now continuous monitoring because of the mobile data. So every night that the patient sleeps or consumer sleeps, and then the next day the data is ultimately backed up to a cloud-based monitoring system. Now, because of this initiative, it's largely increased the number of sleep nights that we've monitored, more than 8 billion sleep nights. Our solutions, which is called AirView, which I'll explain in a little bit more details, and also MyAir, has close to about 13 million patients that is being actively monitored. And we support that monitoring with healthcare professionals and home care providers. And in MyAir, it's a consumer-facing app that almost 3 million patients have signed up and are actively empowering themselves to monitor and improve their sleep health. So this essentially 2 solutions. Next, please. So when we talk specifically about the remote care monitoring solutions, there are 2 that ResMed is supporting in the market. The first on the right, it's AirView, which is a cloud-based monitoring system that is actively used by healthcare professionals and also home care providers. So essentially, it allows that continuous monitoring, the intervention, and it basically sits anywhere accessible by mobile and also on the desktop. Allows the healthcare professional to look into the therapy, the quality of the sleep therapy, and then allows them to offer timely intervention to the patients. Now on the left side, there is an app that the consumers and patients can download off the App Store. Basically, it reads off the same machine and same data, but they will get a sleep score at the end of every night, which is a combination of how well they have slept, how the equipment, the mask and the machines are working for them, and it also encourages them to improve their sleep. There are coaching resources that is available, anything from how to better clean for your equipment to how to get better sleep hygiene at night. So these 2 solutions have been in play especially in Southeast Asia over the last 2 years. There's close to more than tens of thousands of patients now being actively monitored in countries in Singapore and around the region. So what it is, it offers continuous monitoring, it offers timely intervention, it really encourages people to take control of their sleep health, and it provides a basis of more quality dialogue between the physicians and the patients. So I'll hand the time over to Mary that will introduce the Baxter solutions. Mary, please.
Thank you, Mervyn. Good morning, everyone. I'm very excited to be here. Next slide, please. Today, I will share a little bit about our remote patient monitoring system called ShareSource. Next slide. ShareSource is really designed for a patient like him, an end-stage renal kidney disease patient. Globally, over 2 million patients like him require dialysis or kidney replacement. The way he is doing it is actually through a machine that pumps dialysis into his abdominal cavity to draw the toxin. This process takes about 8 to 10 hours at the comfort of his home while he or she is sleeping. In the recent years, Baxter had created an innovation called ShareSource that actually can upload his data, therapy data, next slide, please, into a cloud. Next slide. Next. Sorry. Into a cloud for a clinician to review the next day. Next slide. It's a very simple process, actually. At the patient's comfort of home, the modem's connected to his machine, and then the data is uploaded for the clinician to review a bunch of patients at once or specific patient. The clinician can actually also remotely modify the therapy from the clinic while the patient is still comfortable at home. We have found in recent years ShareSource to be very successful. We have launched over 70 countries with 48% penetrations. This percentage, of course, varies greatly from country to country. Next slide. What we see that the benefit of ShareSource is very clear to the clinicians and to the patients as well to the hospitals. From the patient's perspective, they feel very confident on the therapy because for the first time, they know that a caretaker or hospital clinicians are viewing their data on a constant manner and able to intervene when necessary. It helps with their compliance and staying on the therapy longer. For the clinicians, for the first time, they have continuous stream of data for them to review and proactively intervene and manage that complications at the early stage. It also changes the way the clinicians manage patients. Now on the dashboard, they see a whole bunch of patients and they can reallocate their resource to the most needy patient. And for the hospitals, while the complications are managed, then the hospital do not have to serve the high complication renal patients and can reallocate their resource better for other more critical patients. Next slide. So all these benefits sounds really good. But however, as we're launching into various countries, what we find is that there are two phases area looking at. In the first phase is getting into the accounts in the hospitals. And often the doctors are very enthusiastic in bringing ShareSource into the hospitals. We have to work with IT and legal because there are concerns, of course, with data privacy, data storage, and data breach, which are all valid concerns. And the local countries' guidelines and regulations on these are actually also changing right now. Because remote monitoring is still relatively new, especially fueled by the pandemic, getting more popular. So many countries are changing, and therefore this whole process is not very crystal clear yet. And the second part is when we actually launch in the hospitals, we find that doctors are very enthusiastic putting patients onto remote patient monitoring ShareSource. But after a while, it does create a burden on the nursing power because all these remote patient monitoring activities like monitoring the patient, proactively calling patients, and changing prescriptions all takes time and effort. And reimbursement-wise, it's not there. I think recently the paper by APACMed have shown that in many countries, the reimbursement in Asia-Pac region is not there for remote patient monitoring. As I was talking to Mervyn and sharing the notes of AirView and ShareSource, we realized we're very similar, especially in our journeys and some of the things we're working with. Mervyn, would you like to share your perspective on this as well?
Yes, certainly. Thanks, Mary, for really driving the context. And I think the why for remote care monitoring is very strong. And our personal and professional experiences in the last year and a half has shown that the level of digitalization required, to maintain care is really important. I'll probably just share two perspectives before we hand to the panel. It's firstly, I think it's great, digital health solutions and technology alone will not solve the pain point. It is how we proactively work with healthcare professionals and with all ecosystem stakeholders in order to drive that seamless experience and that ability to operationalize, a care model that works for the system and works ultimately for the patients. The second point and the final point that I'll make, it's really, I think this is going to be a decade of, self-empowerment on health. The, healthcare and also in education are being seen as two sectors that really can be infused with a tech, enabled care model. And really we see that if we can successfully, look at it from a practitioner level and how to facilitate care models with digital health solutions, it will greatly empower the system, the institutions, but also enable patients to take better care and continuous care of their health. So this is where we're coming from APACMed perspective. Yeah. But hand it back to you, Mary, and to Roberta.
Thank you, Mervyn. Actually, Mervyn's the one who said, hey, let's work with APACMed and bring the doctors in so the doctors can talk directly to our community of agency and policymakers and vendors and hospitals, so we can all work together. Like what Mervyn said, totally resonate. We all work together on this journey to transform the healthcare and bring more patients and more patient monitoring. Thank you, everyone. I'll pass it back to Roberto for now.
Thank you very much, Mary. Thank you, Mervyn. I would like to invite Dr. Marjorie to join our session today now. And if you can share your screen to present your slide, please. Thank you very much. Over to you. And thank you again for being with us today.
Okay, can you all see my slides? Okay. Okay, so we will start.
Perfectly.
Yeah, so I would like to thank I'd like to thank the organizer for the invitation to participate in this remote patient monitoring webinar. And I've been asked to talk about how it is enabling agile healthcare infrastructure. So in the next 10 minutes or so, I would like to in the next 10 minutes or so, we're going to have an overview of how the global population has changed in terms of demographics and health trend, followed by the healthcare transformation and how it affected the dialysis population. So the population demographic is no surprise that the world is getting older, and we are heading for a fuel tsunami. And not only that, we also have a high incidence of diabetes. In looking at the trend is increasing at an exponential rate. So is the trend of hypertension globally, and also obesity. So with these three comorbidities on the rise, it's no surprising that kidney disease being on the receiving end of poorly managed diabetes, hypertension, and obesity, we are struggling to keep the chronic kidney disease burden low. But looking at the disease burdened map here from the global health, you can see that most of the causes of kidney disease comes from diabetes in every part of the world. Perhaps just only Latin America has been spared. So diabetes and hypertension is the main culprit as to how kidney disease develops around the world. And this slide just basically bornes out the fact that people are getting older when they get treatment for kidney disease, for dialysis. And you can see in the over 75 is very high in China and Taiwan, but in the region of Malaysia and Singapore, we can see again, the over 65 seems to be the majority of age group that gets into kidney failure and requiring dialysis. So it is borne out by the fact that we're getting older and we are having more comorbidity to deal with. So where does dialysis help us at this point in time? It is predicted by the end of 2030, we will have about 14.5 million people requiring dialysis. But unfortunately, we can only afford to give treatment to 5.4 million, which is a third of the patients will receive treatment and 2/3 will not be able to receive dialysis. If you look at where these people are lying, which part of the world are they? And if you look at Asia, in Asia countries, the demand is tremendous and supply is not there. So if you look at in Asia countries, only a third of the patients requiring kidney replacement therapy will receive it. And needless to say, in Africa, only 16% of patients get their treatment that they need. In affluent countries of North America, you can see that a lot of people, the supply outweighs demand. So why does it happen like this? And if you look at home dialysis therapy, which is peritoneal dialysis as an example, it is noted that affluent countries in the dark brown areas are the ones that are offering treatment for their population. And in this part of the world, in Asia, Southeast Asia country, we can still see some yellow color, which means that there are less the patients receiving dialysis is not a lot. And in fact, if you look on the left-hand side here, in terms of the income countries on the left, in the low-income countries, 68% are not even offering PD in their population. So why is that? I mean, not surprisingly, cost probably is one of the main reason why some countries cannot afford or to give dialysis. So if you look at the cost between the modality of HD and PD, in the high income countries, which is categorized by the World Bank, you can see that there's a big gap between HD and PD, but this gap in terms of cost seems to be getting less as you go down in the income groups in the country. So if we can reduce this, then equity of dialysis may occur. So putting this into numbers, with the exponential growth of kidney replacement therapy, it can really drain the national health budget. And if you look at what actual numbers are we talking about, in hemodialysis, for example, the range of dialysis per year can range from 1,500 to 100,000 in affluent countries, and PD from 5 to 100,000. So there's a big range, a big gap in terms of costs and in where dialysis is being offered. So how can healthcare transformation help this along? So what we can see is that the global healthcare spending is increased. There's no doubt about that. And it's not only in America, it's all over the world. Every country, every country of the world is showing increase in healthcare spending for different conditions. So why are we spending so much? Why is medical bills killing us? If you look properly at what happens is that, in fact, there's only 8 risk behaviors that drives 15 chronic conditions, that drives 80% of the cost of chronic kidney disease worldwide. So if we can target the 8 risks and behaviors, we could potentially drive down the whole kind of like algorithm. So what we do is that in transformation of care, the transformation of care to personalized health treatment, targeting the diet, the smoking, the sleep, etc., and alcohol, in transforming it in the way you work from the reactive to proactive to preventative and then precision medicine. It is no surprise that creation of a new value-based model of care, focusing less on model and product, but more on the outcomes and holistic care. So this is where the healthcare transformation is moving towards. Now, this was taken from Time magazine over 10, 20 years, the covers. And in the very beginning, we were quite worried. Are we too wired? Is it good for us? Then now on the other picture, you can see we are never offline. So the question you ask yourself is, could we use this to our benefit, and using online, using all these sensors to help us so that we don't reach, we don't come to this into this bed. Now, are we ready? Are we ready in terms of the healthcare transformation? I think if you look at the healthcare Internet of Things, we are already using a lot of this for monitoring, diagnosing, and treating. And to be honest, if you look at all these pictures that's been taken all over the world, I think we are nearly there. We are there, but it's just how we can, scale it up. So the future of healthcare, as I see it, is that today's system is reactive. It has to be proactive and preventative in the future. Currently, one-size-fits-all treatment is no longer going to be available. The future would be configurable and personalized. The current system is siloed and analog, but the future would be intelligence-based, crowdsourced, and artificial intelligence, right? And the power is no longer centralized and paternalistic. It will be decentralized and democratic, where patient has the power of what they want. Then how can technology help us? This is what is important. Currently, our care is episodic. Okay, we see the doctors every 3-4 months and get medication. But nowadays, with the wireless, with remote monitoring, we are connected. And even better in the future, being connected and with the AI and decision support system, we can even personalize to what individual healthcare needs are. But finally, whatever it is, it has to be simple, efficient, and affordable. Just going to go through how remote monitoring in ShareSource has actually helped. So if you look at what matters most to patient in terms of dialysis is to reduce hospitalization and technique failure. So this study that was done in Colombia has shown that comparing a group with and without remote monitoring, there was the one in the remote monitoring group has a reduction in hospitalization rate of 39% and a reduced hospitalization days of 54%, which is quite commendable. If you look at another study on technique failure, again, they have shown that, again, using propensity scoring, there is a significant difference in terms of technique failure. Those who are on the remote monitoring seem to do better and stay on PD for a longer period of time. Now, if you look at a bigger study, a cohort study, over 6,000 patients were studied, of which a quarter of them were on remote monitoring. And again, similar results were being shown with 24% reduction in hospital admissions, there are reduction in hospital days, as well as reduction in technique failure. So this, again, has been borne out true that remote monitoring does, at some point, that does help to reduce, to improve outcomes of our patients. Now, this looking at the longitudinal experience, looking at a group of patients, very telling is that, number one, with remote monitoring, they were found to have more changes in their treatment. And with these changes, it was associated with less dropouts, less hospital visits, and indirectly, you can see there's also quite a lot of cost savings in terms of travel costs and also time saving for the nurses and patients and doctors. So, are these important? Yes, those are tangible factors you can monitor, you can see, but there are intangible things that you can see, like, say, for example, patient time saved and care team time improvement, non-compliance to prescription, overhydration. These are all reduced from between 20 to 50%. And these are markers, surrogate markers of mortality, morbidity, and also quality of life. So we can assume that this actually, to some extent, improves patients' quality of life. And how does it also affect the way we work, the way nurses work? And we do see that because of remote monitoring, the work has shifted from a reactive to a proactive mode in this study. And as a result, there's also reduction in clinic time as well as annual visits for the patient. Now, this is a share source graph with a courtesy from Baxter. What we have seen is there was one sent to me in February and then in July of 2020, and the number of patients using the treatment has increased tremendously over a short period of 29 months. And if you look at where these numbers have come from, and in fact, some countries has doubled, the US has doubled the use of remote monitoring in PD. We have increased quite tremendously over the last 2 years. And every country has now beginning to adopt remote monitoring for PD, at least. There must be good reasons for that. Now, in telehealth and home, this is a very good overview from Susie from US, and they basically look at this because of a COVID subcommittee, and whatever they have said here is actually being borne out true, in the sense that there are barriers that we need to overcome. There are stakeholders and patients buy-in that we need to have, and also the advantages I've mentioned earlier in terms of the various improvement in outcome for the patients. And lastly, for it to stick, we really have to look at the platform, the refinement, the outcomes, whether it's really value-based. This is where we need to go in the future. And finally, perhaps to refine the regulations regarding telehealth. Thank you.
Thank you very much, Dr. Fu, for this wonderful presentation. I think you touched upon a number of topics that we are trying to address at APACMed as well. So very happy to hear your perspective here. So let me now invite our next speaker, Dr. Kamonvan, for her presentation. Thank you. Over to you.
Right. Can you hear me? Sorry.
Yes.
Yes. Okay. Right. Thank you so much for having me here today, and thank you so much for joining our topic today. As Dr. Fu discussed how important of implementing digital technology to healthcare system. So I would like to talk about strategy and action plan of sustained RPM adoption in view of peritoneal dialysis practitioner. Next slide. This is outline of my today's topic. I'm going to introduce RPM-PD, which is short for Remote Patient Management in Peritoneal Dialysis, and its barrier, how to set up RPM-PD program and overcome hurdles. Next slide. I will start with a brief overview of RPM-PD by this cartoon. Basically, RPMPD is a cloud-based connectivity platform that allows dialysis data and prescription transferring between healthcare practitioner and patient. Tech company involve only technical services and unable to access treatment data to ensure data privacy and security. All digital transmission will be encrypted into binary code. Next slide. This advancement transformed the way that we retrieve dialysis data from manual record and monthly review at clinic visit to ready on-screen data for everyday monitoring. So it is obviously superior to all practice in terms of precision, clarity, integrity, and timeliness. Next slide. Also, there were many convincing evidential benefits of RPMPD to all level stakeholders as Dr. Fu presents, especially during COVID-19 outbreak. Next slide. Despite appealing concept and benefits, RPM adoption is still limited. Recent marketing analysis show less than half of APD patients use RPM. One publication on 2018 explored barrier of telemedicine adoption, show technically challenge were the top reasons. Cost and resistance to change probably refer to increase of workload or change their practice account for 8%. The following reasons include reimbursement, old age, and low education contribute about 5%. Next slide. To simplify how to succeed in RPM, I will break it into two parts according to timeline. First is how to set up RPM program in model of RPMPD, and second is how to accelerate adoption and keep user on track. Now I'm going to start with how to set up RPM program. Next slide. First step is self-assessment. In this step, you may have to ask yourself whether RPM is the right decision for your institute with following questions. What the benefit you're going to get, how much it costs, and your budget. Why we need it? Do we worth it, or does it worth to your center? Who will involve? Who really need it? Feasibility issue include infrastructure, team, and support, and also data safety. Answering each question will become information for next step. Next slide. Based on your opinion in the first step, you might conclude that RPM is your solution. However, you also require ideas from and listen to your team. So you need to plan whom and what you are going to talk to. From my experience, I need to talk to clinical director who had authority to say yes or no to your proposal, data manager, IT staff, PD team, select patients, and tech company. Then we need to talk about how to share data, safety issue, how to integrate with existing program and benefit and cost. Next slide. With agreement in the second step, now moving to the next step by setting up operating process and integration. On the left-hand side is an example of device workflow, but we need to develop operating process by integrating device workflow to your pre-existing PD program. Then discuss to your team whether who should respond on each step. Next slide. Next step is to select appropriate patients. Key is selecting anyone who would benefit from RPM program and being qualified in terms of digital literacy, infrastructure, finance, and support. Here is an example of my selection criteria for peritoneal dialysis patient. Next slide. And according to concern of data protection, the final step is signing consent by every level stakeholder. Next slide. After RPM adoption, next step, we need to think about how to maintain user and get them to achieve highest benefit. In this section, I will discuss role of each stakeholder. Next slide. Next slide, please. Yeah. For healthcare practitioners, first of all, they should be open-minded and positive on what they are moving through. Good attitude make them likely to offer this option to their patient without bias. Because a bunch of data is retrieved every single day, then authorized healthcare practitioners should consistently review patient data and proactively manage if any derailment is present. Most of chronic ill patients such dialysis love to know what is going to be after treatment. So organizing group discussion and feedback with healthcare team and other patients would give them great opportunity to share and listen. Although digital literacy contributes only small parts of RPM operation and less likely to cause any problem if tech company provide excellent services. It might be bothersome for some people who do not get used to it and need to call for help every time. So background digital skill may affect satisfaction and influence dialysis counseling. Next slide. For patients, select appropriate cases in order to achieve highest benefit from RPM. For example, patients who live in area with accessible broadband internet may have less technical issue than patients who live in area with poor internet signal. And again, digital literacy can predict how well they perform RPM. If patients have less digital literacy or competency, they're looking for support from their caregivers. Next slide. For hospital or clinic directors, they have to understand new concept of RPM as online patient review is right now account for workload. So they should provide support include device workforce, time promotion, and payment to PD staff. Next slide. Then turn to tech providers. 24/7 technical service reassures safe and stable treatment to both healthcare practitioners and patients. Respond to feedback affect user impression. My story, I will contact Baxter the issues about data display. Later on, Baxter changed the design of RPM according to my suggestion, which is very impressive. The design of user interface and display is also important. Mainly, it should be clear, simple, and provide adequate information for decision making. I personally prefer infographic and less button or mouse click to get information. As previously mentioned, digital skill would affect how users perform RPM. Then it is good if tech companies are able to set training program and provide online resource for users. And it would be better if tech company can include treatment-related application service or AI within RPM. For example, clinic visit reservation, blood patient monitoring, or wellness analyzers. Price points is also another big consideration. Data breach become more interest as health data can be used for exploitation in some business, such as health insurance. So it is crucial that all RPM programs must follow data protection regulation and keep with security protocol. Next slide, please. Next slide. Yeah. Actually, this is my highlight of today. Then we usually think about what policymakers can do to improve RPM adoption, and we usually refer to infrastructure development. But for me, I think we might go to the root of digital health ecosystem. We could not deny that healthcare practitioners still play a vital part of digital health. Then we should start off with development of digital education, skill, resource for our staffs. I recommend digital health knowledge should be included in part of healthcare training or become one of education program or career as in developed country. Policymakers can also set policy, budget, and application to enhance and control digital health operations, such as reimbursement program and data protection to ensure digital health users, as well as they can support by providing basic digital device. Reimbursement model might be different in different areas based on background economy. Government might fully reimburse or need co-pay with patients. Reimbursement might be yearly or monthly package, pay-per-review or management, or performance-based reimbursement. Finally, I believe digital health will become broader diffusions according to movement of the world toward digital technology. This disruption could not be done by policymakers alone. So forming partnership with private sectors such as company, logistics services, network provider, and so on could be accelerate the growth and expansion of digital health. Next slide. Here's my conclusion. RPM is disruptive technology that provides benefits to peritoneal dialysis. And in my opinion, there are 5 steps to set up RPM program, include self-assessment, discussion, operation testing, and integration, patient selection, and consent. And contribution of all stakeholders is crucial to get succeed in RPM. Next slide. Thank you.
Thank you very much, Dr. Kamawan, and Dr. Marjorie as well. And good morning to everyone. And again, thank you for joining us this morning. We are now opening the floor for any questions from the audience. If you do have questions for Professor Marjorie and Professor Kamawan, as Roberta has mentioned earlier, please feel free to type your questions using the chat function with the button located at the bottom of your screen. I'm sure everyone is familiar with the Zoom already by now. And again, thank you both professors for your wonderful presentations. Let me see if we have any question right now. Okay, while we're waiting for questions from the audience, let me first throw a few to the both of our professors here. Okay, Dr. Marjorie, you talked about the future of healthcare moving from continuous to proactive to personalized. Where would you say the region is or Singapore is in terms of maybe heading to that direction of having a more personalized approach to healthcare? Dr. Marjorie, I think you are on mute.
All right, yeah. Thanks for the question. I think in terms of adopting information technology for healthcare, Singapore is actually, quite advanced and heading in that direction. And in fact, we are, we have office set up for digital transformation of healthcare, and also the pandemic has pushed forward this initiative, and we can see it from we are adopting things like teleconsult, telemonitoring, and also the fact that we medication delivery all kind of like online. So I think we are getting there as and it's actually in Singapore we're very open to innovation.
Thank you, Dr. Marjorie. That is good to know that we're making good progress on this front. Dr. Kamawan, again, thank you for sharing, the steps in putting up share source in your practice. I just wondering, in your experience, was there any kind of reluctance among the PD team when you first talked about, bringing this platform and integrating this in their routine work? And how were you able to kind of convince them, that this initiative is value adding?
Thank you so much for the question. Yes, we should see hesitation always there whenever next movement. Unsurprisingly, data show digital challenge and resistance to change is one of the top barriers for RPM adoption. I think this is basic mechanism to protect them from breaking out from their comfort zone. In my opinion, there are two keys to overcome this barrier. First is good relationship. If your background relationship with your team is good, then it will be easier to get them into what you want. And second is approaching, which means how you discuss with them. I think it is common that people want to know what is going to be before it happens, so they can prepare themselves. Then prepare information such how it works, how they involve, and what is gonna happen, benefit, problem, and support ahead discussion. Tech company can also provide this information and present to them to the best. Key person who is going to approach them should be one that they trust the most. Another approach is organizing an event to let them attend RPM programs in successful unit by themselves. From my experience, I was so lucky that I had a chance to attend early day of RPM first launch in UK. I mean, maybe 2015 or 14, I joined PD team for 2 years, that enough time to know both strong and weak point of RPM. Then I was able to tell my story to my team.
Thank you, Dr. Kamawan. Yeah, I believe you, and I hear you. Good relationship and communication is essential for this platform to succeed. Going back to Dr. Marjorie, you've shared positive patient outcomes and some cost savings with RPM from reports in other countries. Have you observed the same benefits in your settings, similar to what has been demonstrated in the published studies?
Yeah, so at the moment, we are trying to gather more data to see how, in terms of quality of life and what the patient thinks about the remote patient monitoring. We haven't got solid data, but looking at the way things are, there definitely has been benefit for the patients in terms of cost and travel time, and also, especially in this pandemic, the reduced risk of getting infected with the COVID. So the benefits will certainly be there, but the quantum will be different from what I mentioned earlier, because the quantum of benefit will really vary between what actually the healthcare framework is like and the reimbursement structure. And each system has to just work out, calculate, what is the value of their remote care in their region with predetermined outcomes like quality of life or mobility and cost savings.
Okay, well, eager to look forward to, any additional, data coming from your clinic, Dr. Margie, on these outcomes. We have a question actually from the chat. The person said that we see apprehension, especially in the government clinicians, to use RPM for medical legal concerns. Any suggestion to address this from a clinician perspective? Any of you can probably get to this?
So could you, sorry, Marvin, could you say again?
There has been some hesitancy, especially among government employed doctors, to use this RPM because of medical legal concerns. So are there any kind of suggestions to address this from your perspective?
In terms of, you think the problem with the government and medical legal issue, is that right? I think is depend on area that you ask the question as well. It depends on how the government regulations have any regulations on data privacy or security in their country. For example, in Thailand, we not quite really release this act or this regulation, but we propose to release it maybe next year. It's about how to make data, digital data, and healthcare data secure. The only thing that we need to do by this time that some countries haven't done this thing like Thailand, I think we need to follow what is going on in other countries. For example, in Europeans or even in America, they already done. They have acts. They have act to regulate what about the data safety things. They have HIPAA to control how to share data to the insurance business. So that we need to follow the model of that country. I would prefer to say that. I think in Singapore might already have released this act or this regulation, and probably in terms of company or a hospital or medical staff, we just should follow all this regulation. This could be one thing to reassure safety of data sharing and using this digital health for our patients.
Thank you for sharing your thoughts, Dr. Kamalwan. To keep to our time, let me just ask just last two questions for both of our speakers. I know both of you have been using RPM in your respective clinical settings, and already Professor Kamalwan have shared what was needed initially to launch this tool for your patients. What were your biggest barriers to scaling up adoption of this healthcare technology? One, and second is, how do we proceed to making RPM like the norm for renal healthcare in PD patients? And how can possibly, the different stakeholders in the care of PD patients help to bring this innovation to more PD patients?
I think what's important thing I think is the answer is based on what Dr. Fu have already presented, that we already know the benefits. And I think every stakeholder already know that digital technology already be in healthcare system, and it can help our care for our patients. So if we based on this belief or in this concept, everyone should really pleased to adopt this thing to our practice. And what I would like to emphasize about what strong point of RPM is that it can enhance home-based therapy. If you know that the best thing that we can, the concept of healthcare system right now might a little bit deviate from its real concept, because people usually think that everything should be centralized in the hospital. So RPM might be the important tool that could enhance home-based therapy. And RPM is also cutting down expense for transportation and other expense that patients need to use for clinic visit. And amid COVID-19 outbreaking, it can avoid overpacking at the emergency department and clinic visits. So I think this is a strong point of RPM that would be really important to state to all stakeholders. For role of all stakeholders, I think I already discussed the role of each stakeholder in my presentation, but what I would like to emphasize is that we should start off with education of digital technology, which would be supported by our government or policymaker, because digital technology is usually, it gradually diffuse to our routine. And also for policymaker, preparing budget and making policy to support healthcare practitioner, patients, hospital, and tech providers should be prioritized. Finally, important thing for each stakeholder is that need to, as you all have contribution on RPM. So forming partnership and cooperation between stakeholders would be empower RPM implementation and sustainability.
Any additional comments, Dr. Marjorie?
Yeah, so I think just to add on is that for anything to work, and it was on in my slides, the barriers that it was already there. But I think in essence, if you make the whole process simple, efficient, and secure, that will cover all your PDPA problems, and most importantly, affordable for the countries to use it. And the other thing is that somebody was saying over here in the chat group that how do you make people do it? There's no easy way. It's a change of mindset. Really is a change of mindset. And if you can convince people that it's useful, it will improve their health, improve their their pocket, I'm sure they will take it on.
Thank you both. Thank you, Professor Marjorie and Professor Kamal, for sharing your thoughts. That's all the time we have for this Q&A session. But if anyone, should you have any additional questions, we are monitoring the chat. Please do continue just typing them in via the chat function. Over back to you, Roberta, for the next session.
Roberta, I think if you don't mind, I can go ahead and get the ResMed section started. I know we're moving along quickly here. Thank you so much, Marvin, and the previous speakers for all of the insights from the Baxter side. I know there's a lot of I think similarities in what in terms of RCM adoption in the field of sleep health. So I'd like to go ahead and introduce our next two panelists here. We have Dr. Liao at Singapore General Hospital and Dr. Naricha Tirakalasan, I'm so sorry, at King Chulalongkorn Hospital in Thailand. And I think both of them have some very unique experiences with adopting RCM for sleep medicine. So I'll go ahead and mute myself, and Dr. Liao, if you'd like to start with your presentation.
Thank you. Thank you, everyone. And thanks for inviting me for this talk. It's a great honor. Very good afternoon to you. So I'm going to start with our experience with the implementation or the planning of remote care management in sleep disorders, our experience in the Singapore General Hospital. Next slide, please. So very briefly, OSA is a big problem in Singapore. So Singapore has a population of about 5 to 6 million people, and the prevalence of moderate to severe obstructive sleep apnea is as high as 30%, which is one of the highest reported incidences in the literature. The vast majority of these patients, up to 90%, are undiagnosed and untreated. So we have a huge problem. Next slide, please. So why did my lab start to think about the use of remote care monitoring? And that's because we feel that it will make a big difference in terms of improving the outcomes for our patients. The largest and the landmark study that I have put up here is a study that was published by Atul Malhotra and also our very own Maureen Crocker. This was in 2018 in CHEST, so 3 years ago now. And it was a retrospective analysis of 128,000 CPAP users. And what it showed was that the use of remote care monitoring improved the rate of adherence from 70% up to almost 90%. And patients who use remote care monitoring technologies had improved in average daily usage of up to 1 hour per day. So it made a big difference in this American cohort. And since then, several studies have confirmed these findings. And this has made it into the latest edition of the ASM OSA guideline. This guideline was published in 2019, and you see here that the ASM now suggests that clinicians use telemonitoring guided interventions during the initial period of PEP therapy in patients with OSA. So this is good enough evidence for us, the clinicians at the front line, and this is something that we would like to actively implement. Next slide, please. Now, that paper that Malhotra and Maureen published was 3 years ago, and at that time, it was something that we read with interest, and something that we always thought would be quite useful and quite cool when it comes eventually. We thought we had time to implement this, but COVID came along, and there is a lot more urgency for us to put this into place. Next slide, please. So why did we decide to use remote care management during the COVID pandemic? What is our unmet need? So we can look at it in a few ways. When it comes to CPAP use in patients with OSA, we need remote care management for the initial titration phase for our patients, and also for the long-term management of these patients on CPAP. It is well known and well recognized that during the initial CPAP titration phase, this is a crucial period for us to improve the compliance for our OSA patients. This comes from the ability to do rapid troubleshooting in terms of improving mask leak, resolving AHI issues, and also giving patients the positive feedback and also empowerment so that they can play an active role in their own care. And these interventions have been shown to result in clinically significant improvement in their adherence rate. This is something that traditionally we could only do when we had the patients come and visit us in the sleep lab, so that we can download the data on the SD card physically. But with the COVID pandemic, we thought that if this is something that we can do remotely, it would both improve outcomes, also reduce the number of physical visits, reduce the risk of COVID transmission to our patients at the same time. When it comes to long-term care, we used to see our patients physically every 6 to 12 months to ensure that their compliance is adequate, and also to deal with any other long-term medical issues that may crop up. And if we could do some of this monitoring remotely as well, it would also help very much in terms of reducing the risk for the patients, in terms of reducing their need to travel. Now, number 2, can we meet this need with something that already exists? So right now, we don't have something that can replace the role of remote care management. And the third question is it worth the investment of time and resources to implement this new technology and workflow? So I would say that right now, the guidelines and the meta-analysis suggest that this is clinically effective. Whether it is worth the investment of time and money and resources is something that I think is not clear yet, but we have to start somewhere. We have to start somewhere so that we can get some pilot data, and then we'll know whether it's worthwhile and have a positive return on investment. Can I have the next slide, please? Now, this is a very useful way to look at the implementation of any remote care monitoring technologies. This is a stakeholder empowered adoption model that was first popularized by Alison Marshall from the University of Lancaster in 2013. And it provides a framework that recognizes the values of all the different stakeholders. And it proposes a structured approach to incorporating all these different values within the product design process. So you can see here there are 4 key stakeholders, and each stakeholder has a different set of values and perspectives. For example, the APACMed group that represents the sorry, something happening with the slides. Yes, thanks. So the APACMed represents the technology provider, and what they want is something which is workable and efficient and scalable to a large market. And of course, they want something which eventually will prove profitable and sustainable. But for healthcare organizations, what they want is something that's cost effective and also clinically effective. For us, the doctors at the front line, the professional clinical staff, we want something a bit different. What we are after predominantly is patient safety, something that can improve clinical outcomes, and very importantly, something that has minimal impact on our work processes. By and large, clinicians are very old-fashioned, and we really don't like anything that upsets the status quo for most of us. Patients, on the other hand, they want something which is easy to use and has minimal impact on their daily life, and something that that has rapid support if needed. If you look at this graph here, the horizontal line is the most important, and this horizontal line must drive the whole process between the healthcare organization and the new technology. The vertical dotted line is a bit less formal, but no less important. Can I have the next slide, please? So for us in SGH, I've listed here on this table some of the challenges and opportunities when it comes to RCM in OSA. What were some of the challenges and some possible areas that we can improve on? So firstly, when it comes to infrastructure, this new remote care management for CPAP comes with some infrastructural demands. For example, integration with our electronic health records. There's a lot of demands for data protection and some capital costs. So how can APACMed help? I think it will be a lot easier if we can have some common standards, such as common data standards that are easy for hospitals to use and integrate with the existing electronic health records. They must have robust data protection in place, and their technology must be easy to use. Secondly, we may be faced with low uptake rates, especially in the beginning, both in terms of patients and also from clinicians. The technology provider has a more direct relationship with consumers, and they may be uniquely positioned to advertise to patients directly to help to improve the uptake rate for these technologies. For clinicians, on the other hand, it's important to support them with education and with training and technology support to persuade them to use these new technologies. For the medical legal implications, this was actually quite a big barrier for us because there are so many different groups of stakeholders, and the medical legal environment in Singapore is very strict. So it was very difficult to get the legal team from the hospital to come to an agreement with the legal team from technology providers to achieve a mutually acceptable legal framework for these new technologies. So I think it may be easier if all parties can start with a more collaborative relationship rather than an adversarial relationship, so that the medical legal responsibility can be shared. When it comes to leadership support, the support mainly comes in terms of funding. So how do we get the leadership to support these new RCM technologies? I think the opinion leaders has to persuade the hospital and institutional leadership that remote care management is not just a fad. It's something that is very important, and it's something that is here to stay. It is going to become a crucial part of patient care in the future, And in fact, it is a key table stake for all healthcare institutions. So if it's something that you don't have, you're going to lose out to the other institutions in terms of market share, in terms of patient support. The next factor is measuring outcomes. So this is something very important for all healthcare institutions because it's something that we are being gauged upon at a governmental level. So measuring outcomes in terms of clinical outcomes, patient-reported outcomes, cost effectiveness, and return on investment, all these outcomes will become important when it comes to evaluating any new technology. So the technology provider can help us look at this data if the technology can have a good integration with the electronic health records. Yeah, and I think this will help us provide a lot of pilot data to the institutions. Finally, what is the optimal use and mix of telemedicine and in-person care? I think this is something that is not clear yet. At the moment, this whole talk is on remote care management, but I think it's important for us to also recognize that in-person care is still extremely important. So what is the right mix? I don't know. For example, for OSA patients, we used to see patients every 3 months or 6 months or 1 year. With remote care management, we can probably cut that down. But I think it is still important to have the occasional physical visit so that we can maintain this relationship with our patients and also address other issues that cannot be dealt with using remote care models. Next slide, please. So I put a specific slide up to address some of the issues in terms of funding and reimbursement, because I think this is a huge issue. I looked at the ResMed paper that was sent around, and I'm interested to see that really no other countries have solved this. There was 14 case studies that was looked at in the ResMed paper, and out of these 14 countries, there was no funding for 8 countries, and in 4 countries there was partial funding, and in 2 countries I think it wasn't sure what the funding model was. So it remains a problem, and I'll be interested to hear from everyone here to see if they have come to a solution. So basically, we are being pushed or being encouraged to adopt telehealth across all the healthcare clusters in Singapore. For example, we have set a target of 50% of clinic visits to be remote visits by 2022. So that's in 1 year's time. There's increasing use of remote care apps, wearables, Internet of Things. We have digital prescriptions, we have digital deliveries. We have big data and the use of AI to analyze this data to help improve outcomes. So we have all these going on, but our payment models for remote care has not caught up at all. Right now, we only have payment reimbursement models in place for phone and video consultations. We have no funding models established for the use of remote care apps and monitoring, especially if these apps and remote care technologies are used by the patient. So it's always expected that the patient have to take care of all these funding themselves. So how can APACMed or care providers help? I think in the first instance, we have to get started. The reimbursement models may not be worked out yet, but we still have to get started without that in place. Why? I think this is important because we need to be able to provide some pilot data on remote care monitoring technologies to prove to the funders and policymakers that this is a viable care delivery channel in their own right. And then with this, we can demonstrate how the ASEAN reimbursement can help meet the healthcare organizations, the patients, and the clinicians' objectives. At the same time, while we adopt and increase the use of remote care monitoring, we must not ignore care disparities. Delivery models reliant on patient access to technology and internet must not overlook the already underserved. So remote care monitoring must make healthcare more accessible and not less accessible, because not everyone has access to the internet or to RCM devices. Next slide. I think that's my last slide. Thank you.
Thank you so much, Dr. Liao. And yes, Dr. Naricha, if you'd like to present your story on RCM sleep management.
Okay, can you see my slides?
We can, yes, thank you.
Okay, very good. So so thank you very much for the invitation. So it's my pleasure to be here. So my topic is remote care management, stories of success. Sorry. So the outline, we'll be talking about the adoption of RCM for OSA at the single hospital, which is Chulalongkorn Hospital, and then clinical data collected to show value of RCM, the learning curve after implementation, and the recommendation for the new adopters. So let me give you a background of our hospital. So King Chulalongkorn Memorial Hospital is a university hospital. We have 1,800 beds in the heart of Bangkok. We have an excellent center for sleep disorders, which is an 11-bed level 1 sleep lab, and we also have sleep clinic. And we are the first sleep center to establish international sleep medicine fellowship in Thailand. And this is the statistic for our center. So we have around up to almost 7,000 sleep clinic visits a year, and about up to almost 2,500 sleep tests per year. And of course, because COVID-19, the numbers are dropping. And we implemented this remote care monitoring for the CPAP usage, in which sleep clinic at our center and our sleep lab were closed off and on during COVID-19 pandemic. And we decided that since the situation in Thailand is a bit better, so in September in 2021, sleep lab and sleep clinic were reopened. And telemedicine clinic was also implemented by the hospital policy at the same time. However, for telemonitoring system for CPAP, we actually initiated that even before the COVID-19 pandemic, but on case-by-case basis since about 2020. So a little bit over a year, we already started doing that. And we use CPAP with telemonitoring in terms of following up on the patients who already use the CPAP. And I would like to show you this video of how we have been doing for our telemedicine clinic here. I can. So this is our center, our sleep lab. And this is our staff. So this is the virtual telemedicine clinic. So we have the staff talking to the patients, put it in the telemedicine application, and they put the patient in the doctor's room, and the doctor will talk to the patient. They type the notes in the computer. And this is our sleep fellows talking, bringing the patient, put them through the application, and also talk about what they need to do, and also see download data on the iPad. And if you have to order the medicine, it will be digitally prescribed, and we also address the issue. If we have to adjust the pressure of the CPAP, then we also do that through the application on the AirView. And even before we start doing this telemonitoring system, we actually wanted to see whether it works in terms of including compliance in Asian population, like what Professor Leo talked about that before, that AASM, American Academy of Sleep Medicine, recommended to use this telemonitoring system in order to improve compliance during the initiation of CPAP. but the data from Asia is lacking. So we conducted this study to see whether the patient who first start to use the CPAP, whether we implement this telemonitoring service, would that improve the compliance? And we recently published this in the Journal of Clinical Sleep Medicine, the official journal of American Academy of Sleep Medicine. So I'd like to give you a little bit on detail what we did for this study. So we actually wanted to see mainly the compliance change. And we also want to see whether doing this usage will also improve the adherence, but also would there be improvement in sleep quality or improvement in daytime sleepiness or other parameters. So we actually enrolled the patients with moderate to severe OSA who actually reached the optimal PEP titration. And we conducted about a year for the duration of the study. And these are the exclusion criteria. And for the interventions group, we actually give them the CPAP with also standard care with the educational session, which is the video telling them about what sleep apnea is, and then what CPAP is, and what they should expect. For that, we also review the PSG data, and this is the fellow who conducted the study at the time. And in this group, with the standard care group, they actually still allow to contact the investigator if needed. However, in the interventions group, we activate the telemonitoring system, and we would contact the patients if there are any alarming parameters like the usage less than 4 hours, the AHI more than 10, or air leak more than 24 liters per minute. And this is the flow of the study. We, at the end, had about 28 subjects in the telemonitoring group and 29 subjects in the usual care group. And for the compliance data, we actually demonstrated a trend towards improving in average nightly usage hour per total duration of the study. There was also a trend towards improving in compliance for the day of usage. Interestingly, we found very significant difference in terms of employee compliance or adherence with the standard criteria, which is the usage more than 4 hours for at least 70% of the time. And you can see in TM group, the usage with the good adherence was 64% compared to the usual care group, only 34%. And there were also improvement in the leakage and also improvement in the Pittsburgh Sleep Quality Index, indicating better sleep quality if we implemented the telemonitoring system. And since we actually had the research data to support the benefit of improving compliance, which is very important, because now the data has shown, even though if you use the CPAP, but you're not using it enough, if you're not using at least 4 hours, then there's no significant reduction in cardiovascular risk. So I think telemonitoring system, which has been shown in our study to improve compliance, that's really encouraging us to use the telemonitoring system. So since we started this in the past, but not routinely, during COVID-19, we have we are very impressed with the telemonitoring system, because if we don't have telemonitoring system, we will not be able to start our telemedicine clinic, because majority of the patients in our sleep clinic are OSA patients who already started on CPAP device. We also face some technical problem like everything that we recently started. So there's some barriers there. So we actually have problem with incomplete data. Sometimes we look at it, download the data and saw some incomplete data, and we have to retrieve the data again. And some technicians that helping us, they actually don't know how to retrieve the details data, so they only retrieve the summary data. So there was a learning curve there. And there was some technical issues with internet problems sometimes at our hospital. So sometimes it's a little bit delayed. And since we have a lot of healthcare providers in the clinic, consolidate the data also very important, because sometimes the data is very scattered. And the staff learning on operational knowledge is also very important, how to use the software and things like that. And I think the main barrier is the reimbursement of the telemonitoring in long term. Since now we pair these telemonitoring, uploading the data and changing the pressure of the machine by pairing these services with the telemedicine clinic, we can only charge for the telemedicine clinic and the prescription, but we cannot charge for the telemonitoring system separately. So a recommendation to the new adopters. So in my opinion, it's a very promising technology. We have shown the data that it may improve CPAP adherence, particularly during the initial CPAP trial. It's very beneficial for telemedicine clinic during pandemic and even during the new normal. Since the situation in Thailand is getting better, I have talked to the patients, and many patients, even after COVID-19 pandemic, they still prefer to actually doing the telemedicine clinic because they feel that it's very convenient. You know, we can see the data, we can adjust the pressure for them, and we can send them the medication. So they feel that this is very convenient. So we actually decided that for our center, even though the COVID situation is better, we will have telemedicine clinic during the last 2 weeks of the month. So we might implement this for the long term. And it's relatively easy to operate. There's a learning curve there, but I think it's relatively easy in order to retrieve the data and for machine setting adjustment. And we need to establish the system to support telemonitoring reimbursement. So I think that's the issue that we have to work out. So with that, thank you very much for your attention.
And thank you, Dr. Narita, for walking us through how you implemented RCM at your hospital. And I know there's so much information that all of us can talk about, and I'm sure there's a lot of questions here. And in the name of time, I'm going to ask one question to each of the most recent speakers. So Dr. Liao, if you want to clear your throat and come back on, I'll start with you. You had mentioned actually a lot of the same challenges that Dr. Narita had mentioned: reimbursement and payment, new adoption of new technology, and having a bit of hesitancy in terms of something that we're not all familiar with. Do you think that, I guess, what do you think would be the most influential trigger to making a decision to adopt something like RCM at your hospital? Would it be something like clinical data that you mentioned? Would it be a cost benefit ratio or a budget model? So something more along the cost and the administration of it? Or do you think there's another gatekeeper in there that we're not considering that would help you make that decision?
I think in terms of the people right at the top of our institution that makes the decisions, the most important factor for them would be the cost effectiveness of any new technology. As long as you can show that it's not worse than the existing technology, but if it's a lot more cost effective, I think they will be happy to support your initiative. Yeah, but I'm not sure how easy it is to come up with this kind of data, unless we can get something going first, maybe do it for a year or two, then we hopefully can show some of this data. And this is what hopefully we can do at our hospital. ResMed has supported us throughout this, and I hope we can get this started soon.
Yeah, I think you mentioned it earlier, you have to start somewhere, right? I think that's a good approach. Thank you very much for sharing your perspective. And then Dr. Narita, you've implemented it. It's been over a year now, obviously has seen some successes. And you mentioned patients are really liking the experience with remote care. Do you think that would continue? I know you said you want to continue it post-COVID. Do you think that will continue not just in the next 6 months, or do you think that will be something that's more traditional across sleep labs in different hospitals at Thailand, because patients so much appreciate this new technology? Or any thoughts on that?
Yes, I definitely think, I think we all talk about the new normal. So I think we're now going to be reaching to the new normal. And I think in my experience, many patients really prefer the telemedicine clinic appointment. So I think most of the clinic, not just our sleep clinic, I think the telemedicine clinic will be one option for the patients to choose. For example, our sleep clinic, I think after the pandemic, at least 1 week of a month, we will dedicate to that for the telemedicine clinic, in which we will probably likely we only see the patients who already use the CPAP and their device have telemonitoring system, and we'll see them remotely. And that will be somewhat our part of our new normal for sleep clinic in the future.
Okay, thank you for that. I think that makes a lot of sense, almost kind of triaging the type of patient that would be the best new adopter, right? To get some good advocates going. I think that's very good learning. Well, thank you both very much for kind of wrapping up the end of this session, talking about RCM for both parts of today's talk. And I think we might have one more comment to kind of wrap things up. So Roberta, I'll probably refer back to you.
Thank you very much. Thank you all for this wonderful session. I think there is maybe one last question that I would like to ask to all our speakers today. What is the call to action you would like to share with us? And I know I hear a lot, of the topics we are trying to address from an organizational perspective, but what can we do better, and what you would like us to focus on from your perspective? So I don't know if there is anyone who would like to start on that, to share perspectives before we wrap up. Thanks.
I can share on my call to action, and I'm just going to show you 3 simple slides looking at what I feel things should be done. Can you see my slides at the moment? In terms of call to action?
Yes, we can.
Okay.
We can.
So basically, in the call to action, I think looking and hearing what everybody else has said, the remote healthcare has actually resulted in a paradigm shift in how we deliver our healthcare to our patients. And as Common One has said, it is a game changer and a disruptive innovation. Is true. And I honestly feel that in time, it will be the standard of care, honestly. And if you look at and what Dr. Liao has also said, I think we are all living in silos. We have to align our align our transformation perspective, because we all have our own different ways of looking at how it should be done. The executive will look at the KPIs and how they want it to work. Doctors have doctors' perspective as to how they want that KPI to work. And on a general whole, as a view, as a whole, as a nation, and as how people take it on and adopt it, and it's a lot to do with culture and mindset. And I think that this is a very telling slide that I have seen, was that we must get into our heads that our life have changed. And yes, some people can accept it, but we really have to have the mindset of, accepting, adopting, and adapting to the situation that we have. We all travel at different speeds to the end. The wind will change, but as long as you can adjust the sails, you will eventually reach your destination. Thank you.
Dr. Fu, I love this message. Thank you so much for sharing this. I think this brings us to the end of this discussion. Definitely, there is so much more that we could discuss on these topics. So I would like to thank all of you for your work, for the preparation, for sharing your perspective. That's definitely only one small step that we can do, but we hope to engage with you more next year on a number of initiatives that we are planning on this topic. Thank you very much, and I wish you all a nice weekend. Thank you.
Thank you.
Thank you.
Thank you.
Have a good day.
Thank you.
Bye. Thank you, everyone.